Okay. Thank you, everyone. Good afternoon, everyone. It's really a pleasure to have us here today. We're having a very important section today. Please let's remember to mute our mics and take down our questions, contributions, because by the end of the section, we really love to make the section as much interactive as possible. So please let's mute our mic. The section is being recorded, so we're going to be sharing it with a lot of people, so we don't want to have background noises. I'll go ahead to introduce myself. My name is Amaka Obina, a program manager and sick. Today we'll be looking at a very important topic, implementing WHO core components for IPC in healthcare facilities. As we all are aware, every time, patients come into the healthcare facilities, it's basically, for them to, be treated to receive healing. But when we look at it across the world, healthcare associated infections, they continue to threaten the systems that are designed to, protect life. And so the question is not whether we know how to prevent infections. The real question is, are we implementing what we already know consistently, systematically, and being able to sustain the process? And that's where this World Health Organization components comes to play. So it's not just a mere document, it's like a blueprint for safer care. And we're looking at this topic today. So, as we're exploring this topic, I would like us to kind of reflect deeply within ourselves to ask, are IPC programs functional? Are they just mere formalities? Our guidelines, are they visible on are they quite visible on the shelves and also alive in practice? Are we measuring compliance? Are we measuring impact as much as possible? So this section gives us an opportunity, to review these components. I know that this is not the first time we're hearing them. We're also going to be re-examining our commitments to, operationalizing most of this unique context. And, taking us through this section today is no other person than our amiable Dr. Joan Ejembi. She is a consultant clinical microbiologist with extensive experience in IPC based in Ahmad Bello University Teaching Hospital, Azaria. She has contributed significantly in strengthening antimicrobial stewardship IPC practices within the healthcare, and she has vast experience in implementing IPC programs. She has facilitated numerous courses, capacity building trainings, professional development sections for healthcare workers across different levels of care. Her work, not just reflects technical expertise, but deep commitment to building sustainable IPC programs. She holds a diploma in IPC. So you can agree with me that, she's, the main
Market.
person to share her knowledge. Please mute your mic, ma. So you can agree with me that, she is, a very good, she has a pedigree to be able to take up this topic today. She'll be sharing her knowledge, her practical experience as we explore this topic, implementing WHO core components for IPC in healthcare facilities. So let's do welcome our very own Dr. Joan HMP. Dr. Joan, you're welcome. Thank you for taking our time from your busy schedule to be here with us today. Please let's welcome her with her best emoji in the chat. Thank you so much. It's a pleasure to have you here, Ma. You have the floor. I'll stop sharing right now.
Good afternoon, everyone. Good afternoon, Amy. Thank you for that elaborate introduction. I refuse to send you a bio, and you have you have developed one on the spur of the moment. So thank you everyone for making out time. And this is our first echo session for this year. And Amaka roped me into having this presentation, which we feel will be a building block and will guide our activities for the rest of the year. So permit me to share my slides so we can get the ball rolling. So can you see my screen?
Yes, we can. Yes.
Let me put it on presentation mode. So we'll be talking about implementing the WHO core components for infection prevention and control in healthcare facilities. So for this presentation, I think we have just one objective, which is to ensure that by the time we are leaving here, we'll better understand how to go about implementing the core components for IPC programs, as Amaka mentioned in her introduction. So this is the outline I'll use. We'll talk briefly about the core components and then how we go about implementing at healthcare facilities using multimodal strategies. So I always love to introduce such presentations with this excerpt from Florence Nightingale. The very first requirement in a hospital is that you should do the sick no harm. And almost all activities are geared towards ensuring that someone who comes to your facility already ill doesn't go away with something worse than what he came with. And this brings us to the concept of healthcare-associated infections, which are what? Infections that patients acquire in a healthcare facility, which we are not present or incubating at the time of admission. So studies have shown that on average, about 7% of patients in developed countries will develop an HAI at the end of a healthcare activity or interaction, while in developing countries, it goes between 15 and 45%. That tells you that out of every 10 patients that come to a facility in a developing country, the likelihood of going away with the HAI is about 4 or 5 patients having an HAI at the end of that interaction. So the good news is that a large percentage of HAIs are preventable through effective IPC measures. And why are we interested in having, or why did the World Health Organization go on to develop the core components for infection prevention and control? Just as the previous statistics showed, IPC implementation varies globally. And we all know now the world has learned the hard way that the world is only as strong as its weakest link. So a breach in IPC at one part of the world would, in the long run, translate to a breach or a challenge to IPC programs in another part of the world. So we know that developed and developing countries are at opposite sides of the spectrum. They have better IPC program structure implementation as opposed to where we have weak IPC structures, program implementation in low and middle income countries like our dear Nigeria. And the situation is dire in developing countries. Why? Because we have few IPC professionals. It costs a lot to train an IPC professional. If not for the grant from the NCDC and the College of Medicine, University of Lagos, where they developed the program to train IPC professionals. Before then, when I look at the cost of IPC training programs and the cost in dollars, in pounds, I just move. I just keep. I say this one is for the big fishes that can afford it. But now, because of the grants, it has been made accessible and affordable to healthcare practitioners in country. But despite that, we still have few professionals as regards the demand. Then inadequate IPC infrastructure, wash facilities, wash infrastructure. There is no how you can implement IPC, as they used to tell us, the software and the hardware. Wash infrastructure is the hardware you need, while IPC programs are your software, which ensures that your hardware can achieve the required outcomes. And then we usually have vertical programs. You have an IPC program for HIV, which patients that come to HIV programs will benefit. Patients that come to the same facility, other programs will not benefit. So these are things that tend to reduce or water down IPC implementation in developing countries. And then one that has hit us recently, should I say recently, recent times, the Japa syndrome. The few professionals we have are Japaring, few healthcare professionals are Japaring. So now you now have a healthcare system where your available healthcare workers are overburdened. And studies have shown that the risk of HAI is occurring is higher when you have high work pressure. So at this point, I would like us to revise the WHO core components for infection prevention and control. But before I start here, I would like to ask, is there anybody on this call who is new when it comes to who is not aware of what the core components of infection prevention and control are? So that will determine to what extent I will take the next phase of slides. Because I'm assuming that we are all professionals here. So should I continue with that assumption, or do I take time to go through this as well? Please, I'm waiting for responses. I can't say anything.
All right, madam, please go through them again, please. I know I can remember pre-model stage.
Okay. So for the sake of who spoke, although I couldn't see who it was. So this is just a brief recap on the WHO core components for infection prevention and control. So what are these core components? They are basic minimum requirements for establishing or strengthening infection prevention and control programs at national and facility levels. The World Health Organization has done a lot of research. And how did we get there? They discovered that when it comes to IPC implementation, we usually have, just as I said, usually have developed countries at one side of the spectrum. Then you have the low middle income countries at the other edge of the spectrum. But they have, when we talk about evidence-based, studies have shown over time that if you have all these core components in place, at least your facility will be safe in the sense that the basic minimum requirements for patient safety, healthcare worker safety, IPC implementation will be available. And if you have the basic minimum, that means on average, everybody is considered safe, and then you can build on that. So there are 8 core components. And of course, when you say something is core, that means you should satisfy it. So it's not as if you can pick some of the components and leave some of the other components out. The 8 core components we cut across what is required for national programs, and at our level, what we are discussing now, what is required at healthcare facilities. Then based on the level of specialization or the level of care, whether it's tertiary, secondary, or primary, these core components vary. So these are the 8 core components. You have IPC programs, evidence-based guidelines. Core component 3 is education and training. Core component 4, surveillance for healthcare-associated infections and antimicrobial resistance. Then 5, multimodal strategies, which is the strategy we now use to implement IPC programs. Then 6, monitoring, audit, and feedback. 7, workload, staffing, and bed occupancy. And then 8, the built environment, materials and equipment for IPC at the facility level. So these are what we refer to as the core components. And for you to have a structured and a structured program that achieves the requirements, that's keeping the healthcare worker, the patient, the environment safe, you need to address every one of these components. And they are core, just as when you have a core course, you must do it and pass. It's electives that you may do and have a low grade, and you can even drop the elective, but for core, you must do the core and pass. So for IPC programs, what do we mean? You need a dedicated, strong team. You need an IPC team. You need an IPC committee that supports the team in ensuring that the requirements, the goals, and the objectives are achieved. Then evidence-based guidelines. Guidelines are required so that when you are talking about a program or an activity in any part of the world, it's assumed that you're all doing the same thing. So if we say, for instance, hand hygiene compliance, if we say a facility in India has a compliance level of 40%, and we now say another one in Nigeria has a compliance level of 30%, it means that we understand what it implies. And when we say a facility in US has a compliance level of 80%, it means you understand what it implies. And why do we need guidelines? So that things are done properly and everybody does the standards. Everything is done according to standard because guidelines are developed based on evidence. So things are usually done according to standard. For instance, you should have guidelines on how you should set a line, guidelines on how you should monitor central lines. Any problem? Okay, that's about guidelines. Then education and training. When it comes to IPC, education, the method of education has to be didactic and has to be practical because oftentimes you need to change, it needs to change the behavior or the perspective of people, especially if what they had or what they were practicing previously is not in line with standards or not in line with current guidelines. Formally, you could have somebody that will catheterize the patient and leave the patient with the catheter for 2 or 3 months. As long as the patient is not complaining, he doesn't see there's a need to change the catheter. But this is contrary to guidelines when it comes to CAUTI and then catheter-associated urinary tract infections. And then surveillance. Why do we need surveillance? As long as you do not check for what infections you're having and the level, then there is no how you will know you have a problem. I usually say that the only thing that is worse than a high rate of health-associated infections is not even knowing what your rate is at all. If you have a high rate, then you can put structures in place to monitor and bring in interventions that can control and reduce it. But when you don't even know you have a problem, how then do you think your problem can be solved? And then multimodal strategies. Prior to now, if you say IPC, everybody thinks you're only talking about what? Training. And why? Because that was all we knew to do when it came to implementing infection prevention and control programs. We'll just go for training. At the end of training, we'll go back to our offices. Then we still remain at what? Status quo. But the WHO has shown with evidence, countries that have succeeded, why did they succeed? They now use multiple strategies to implement programs. They don't rely only on training. They look at available resources that are required. They look at training as well. Then, of course, they bring in what? Monitoring and evaluation to ensure that those programs are monitored over time, where monitored over time to see whether it's achieving its desired impact. And then we evaluate, are we winning? Are we not? If we are, good and fine. If we are, what can we do better? If we are not, what do we need to implement to ensure that we win and obtain our required objectives? Then are you reminding people that this is the correct thing that needs to be done? And then are you ensuring that it is part of your facility, your part of your facility operations, that this thing, let's say it's workload issues where staff is overstressed or your bed occupancy is more than what's the ideal for your hospital. That means your staff is put under more pressure. There's a higher chance of healthcare-associated infections occurring. Then the built environment. This goes without saying, just as I said, the hardware. If you do not have running water, it is hard to implement infection prevention and control. If you do not have standardized facilities for sewage disposal, it is hard to implement infection prevention and control. If you do not have the required structure of facilities for waste disposal, then it is hard to implement infection prevention and control programs. So this diagram shows us how the various core components, the 8 core components intertwined, are interrelated, and how they should be implemented. You see at the top, we have in orange the IPC programs. Amongst the core components, the first most important is your IPC program, because it is from the program that you can drive and achieve and implement all the other core components. It is when you have a structured program, you can develop guidelines, you can organize trainings for the groups that need to be trained. You can conduct surveillance. You can do your monitoring and evaluation. And then, of course, the enabling environment. What is the enabling environment? The structure. You should have structures that are IPC compliant, floors that are easily cleaned, adequate spacing between beds, ventilation, and all that. Then the requirements for wash, running water, requirements for proper sanitation and sewage disposal, and all that. So that is part of what the enabling environment. Because if you do not have the enabling environment, then even though you have your programs and you have your available guidelines, you can do your training, conduct surveillance, it will be hard for you to achieve the required effects because the environment does not empower you or enable you to carry out or implement the programs. And then for whatever it is they're implementing with regards to IPC, just as I said, it has to be implemented using multiple strategies, the multimodal strategies, not just using one arm like education and training or monitoring and evaluation, but bringing in all the components to ensure that the program does not fail. So what are these multimodal strategies? There are 5 in number. The first is what? System change. And what happens with system change? What do you need to have in place as per requirements, resources, to ensure that the system or program you are building is guaranteed to succeed? For instance, you're talking about hand hygiene, what resources do you require? Do you have your alcohol-based hand sanitizers? Do you have running water in your facilities? Do you have sinks placed at appropriate positions for healthcare workers to be able to utilize them? Do you have disposable tissue for people to dry their hands after washing? Then, do you have IEC training materials? Do you have people that can monitor to ensure that the people are complying with hand hygiene? Do you have people that can conduct training so that the healthcare workers know how hand hygiene should be performed? So what things do you have to ensure that once you commence a hand hygiene program, your program is guaranteed to succeed? Those are things you need to enable you change your system. Then training and education. Okay. Do all your healthcare workers know how to perform hand hygiene appropriately, adequately? If yes, then they might need refresher training. If no, of course, they need to be adequately trained. That's where training and education comes in to improve healthcare worker knowledge. And then monitoring and feedback. Now you have brought in the requirements for hand hygiene, your hand hygiene program, and you have trained all your healthcare workers. You need to monitor and ensure that they are complying with the practice. So you need to assess if people are complying, that's good and fine. If not, what are the problems? Is it that occasionally there's shortage of water in one part of the facility, or the materials required, the consumables, the liquid soap, the hand sanitizers are not there, or they do not have reminders to show them that they should remember to perform hand hygiene? That brings us to the 4th aspect of the multimodal strategy. It should be shouting in everybody's face. This is how we want to go. This is the new change, as they say with political parties, APC. This is the new change anthem. What was that slogan then? I can't remember. Maybe the politicians in the house can remind us. So what is the slogan? So the slogan should be everywhere. People should be reminded, okay, perform hand hygiene. These are the 5 moments when hand hygiene should be performed. These are the steps in performing hand hygiene. And then culture of safety. Do you have, for instance, in your facility, a time when the hand hygiene compliance is conducted, where you can have wards? Let's say this ward was the best performing ward when it came to compliance with hand hygiene. And let's say at the end of the year, where you have your annual meetings or dinners they usually have at the end of the year, you can give prizes to teams that have won. It's now becoming part of your facilities culture to ensure that they sustain the program. So that's where we now talk about the culture of safety. So I hope I have helped refresh the multimodal strategy. So why do we need WHO core components of IPC? As I said, based on scientific evidence, expert consensus, and country experiences, the WHO core components for IPC are the foundation where you need to establish a new program or to strengthen already existing programs to be sure that they are effective at both national and facility level. So there's no need to go and reinvent the wheel. Those that have successes have shown this is what we did that we succeeded. So, which is why we have the WHO core components. This is just to give us an idea of what we mean by having an enabling environment. You can see what the environment is in picture A. So what can we do to ensure that we move from A to B, which is the ideal, and then not just moving to B, but ensuring that we remain in B and not go back to A? Because if you do not have a system in place, give or take a couple of months, even though you have moved to B, you will retrogress back to A. So the core components and the multimodal strategy ensures that you not only remain in B, but you improve, because as I say, quality is not stagnant. You improve from where you are to better, to achieve better successes, better implementation, and better outcomes. Same thing, how do you ensure that you move from A to B and you remain at B and only improve? So that now brings us to implementation. So let me say here that the goal of IPC in the healthcare facility is, one, to protect the patient, then the healthcare worker, visitors, and others in the healthcare environment, as well as the environment. We're all talking about climate change now. And then how do you achieve your first two goals in a cost-effective manner? Because what usually turns off facility leadership is when they think that what you need to do or what you want to do is going to cost them a lot of money. In fact, by the time you are seeing your hospital management and telling them this is what I need, they will give you 10 other things that to them are more important, and it's costing them a whole lot much more money. So yours will be considered nothing, wouldn't be considered as relevant as what they think is relevant. So when you can show that you can achieve a lot in a cost-effective manner, it helps to improve the feasibility of re-implementing your IPC programs. So what's the first step? Preparing for action. And how do you go about preparing for action? You should have a team with an overall lead. They say there needs to be order. So you should have somebody that can guide the team, to ensure that you achieve the objectives. And then going forward, you also need somebody that can deputize in case the lead is not around, because nobody will be around 24/7, 365 days in the year. So you need somebody that may deputize in case the lead is not around, so that the work can be sustained. Then you need to put in place measures that will support successful implementation. They say if you want to build a castle, ask yourself, can you afford the cost before you start? So you do not start halfway and then you have an elephant project that will never see the light of day. So what are the things you need to put in place that will support successful implementation? You need to understand the core components for IPC. I need to understand how to utilize the audit tools that will be required. What are these? The IPCAF, the Infection Prevention and Control Assessment Framework, and other tools that you could use like the wash fit or the hand hygiene observation forms. You need to understand how to do this. When you are preparing for action, if you need to undergo training or a refresher course for this, you need to do that. Then you need to have what we refer to as the position paper. How can you influence or get your facility management interested in improving IPC implementation at your facility? You will need data. You might have information on current situations, negative situations or occurrences. For instance, as flashback, I remember when we talked, there was a story about one baby, Enyola. I don't know how many of us can remember that story, who got infected with HIV at a particular facility. That's negative occurrence. So you can use occurrences to help show your facility leadership why it is important for you to implement IPC programs. Excuse me. And then what recommendations do you have? You should have that put down. Never go to your management with a problem without giving them feasible and possible recommendations or solutions. Then who are those that you need to bring in to your team that can put in word? You need people with interest, people that have power, and people that have influence at various units and within the facility leadership. It's very important to make CMAC your friend. It's very important to make CMD your friend. Okay? And then various heads of relevant units. Then you have people that might not be the heads, but have influence within the facility. Like in my facility, for instance, during the COVID, I leveraged a lot on senior professors in pediatrics, senior professors in medicine, because even though they are not current HOD, they are the kind of people that when they make a statement, the current HOD, sitting HOD will fall in line with whatever it is that they are advocating or whatever it is that they are saying. Then you look at your necessary resources. If you do not have the resources and you don't plan or prepare for it during your preparing for action, then you are doomed to fail. And what are the resources? Both human and financial. You might not have all the financial resources, but you can have an idea of how you can, from time to time, get to management and get resources you need when it comes to the finances, but you can work on the human resources that you need. Members of your team, key people in other departments who might not be members of the IPC team. Oops, sorry. My system is almost going off. Let me connect it. People who may not necessarily be members of the IPC team, but who have interest in infection prevention and control. People who have interest are always a good human resource to harvest. And then look at the infrastructure. Do we have the infrastructure on ground? And then do we have link nurses? If not, then that's one important pool of healthcare workers that are relevant to the success of IPC programs, because you have, especially for those of us that have large facilities, you need as much workforce as you can get. And then what existing programs do you have? Do you have an HIV IPC program? Do you have a TB IPC program? Those are programs you can also bring in and see how you can leverage on them for your own IPC program implementation. Then, of course, identifying stakeholders and meeting and communicating with them. Communication and advocacy is key to the success of infection prevention and control. They used to say that the P in public H is politics. IPC is one place where you have to know how to play the politics. So when you are done with your step 1, which is preparing for action, this is a quick checklist to ensure that you have addressed the important aspects. You should have a lead, know who is your lead, who is your support, your deputy. You have identified your resources, human and financial. You have retrained yourself on the core components. You have available previous data assessment and reports. You have developed your position paper that you use to discuss with management and relevant stakeholders. And you have also formed some integration with other relevant programs like HIV and TB. And then you have secured management and leadership support. That now takes us to step 2, which is what? The baseline assessment. And how do you conduct the baseline assessment? For facilities, what we utilize is the Infection Prevention and Control Assessment Framework, which we really refer to as the IPCAF. It has 8 sections and 81 indicators. And each of these sections addresses one of the core components. So each section addresses a core component. So you can see that the facility program is assessed based on how they satisfy the 8 core components of WHO. So for each core component, it's broken down into indicators, and at the end it's scored. So each core component is scored over 100. So when you conduct the assessment, then you now total your scores and see where your facility is rated. When it comes to the IPCAF, what are the requirements? You should have of course, your team, the IPC focal person, an IPC professional, your team members, and you should have understood the tool from step one, and you should be objective in applying this tool. Don't bring in politics here. If they ask you if you have a program, be sincere. If you have a program, let it be yes. If you do not have a program, let it be no. Because it's when you're objective in applying the tool that the tool can enable you develop your program. I remember when we went for our training, most facilities are categorizing themselves as either basic or intermediate. Only very few facilities agree to classify themselves as what? Inadequate. But I think in the long run, it was better for us because out of all of us, I was the only one that put my facility as inadequate at the beginning. Others put themselves as either basic or intermediate. And by the time you are giving yourself a false beginning, then it's difficult for you to address the problems because you won't have the gaps identified to address in the first place. Then you need to keep a copy for your records and planning. Then very importantly, you should take pictures. Because as they say, a picture is what? 1,000 words. And you need this to be able to tell your story, not just with documents, but also pictures that everybody can see and say, okay, this was what this facility was like previously, and this is what it is like now. Then other tools that can be used for assessments are the hand hygiene self-assessment framework, the wash fit, and the hand hygiene observation form. But we focus prominently on the IPCAF for this presentation. So this is what the tool looks like. This is a snippet of what it looks like at the first core component, which is IPC program. So you can see it asks the first question. Do you have an IPC program? And you're supposed to choose one answer. Is it no? Is it yes? And you can see the scores. If you have a program without defined objectives, then your score is what? 5. If you have a program with well-defined objectives and an annual activity plan, then your score is 10. So you can see in this case, if you choose no, you now see you have to do what? Develop a program with defined objectives and an annual activity plan. But if, let's say, in your facility, you do not have a program, and you now decide to say, I have a program, then you have made it more difficult for you to ensure that you address this gap. So that is how it goes through for all the 8 core components. And as I said, each one is scored over 100. So if at the end of your assessment, you see that your score falls between 200 and below, then it's considered what? Inadequate, and you have a lot of work to do. So it's best to know where you stand and grow from there. So you need to do what? It tells you that your implementation is deficient and you need significant improvement. If it is between 201 to 400, then it tells you that it's basic, your rating is basic, which means that some aspects of the IPC core components are in place, but they are not sufficiently implemented. So you now know which gaps to identify and improve on. And that is how it goes to advance because the total is scored over 800 in all. So at the end of your baseline assessment, using the IPCAF, what should you have satisfied on your checklist? You should have conducted the IPCAF. You should have analyzed the results, know your best performing, your worst performing areas, know which areas have high risk associated, which areas have high impact associated with them, and then what could be your low hanging fruits. Then it's important that you should have given feedback, presenting your findings to leaders and other important stakeholders, the areas where the assessment was conducted and the facility management.
Dr. John, we can barely hear you. I think it's your network.
You should also, at this point, okay, can you hear me now?
Yes, we can hear.
Okay, so where did you lose me?
Yes, ma'am.
Where did you lose me?
Just less than a minute, just few
Okay.
seconds. Just go
So
ahead.
which also so Then at the end of your step 2, which is assessment, you should have had just as you identified your best and worst performing areas, you should have your what recommendations and then a way forward, which now brings us into step 3, where you now need to do what? Develop and execute a plan. And how do we do that? From your gaps identified in step 2, you have your priority areas based on what? Risk, based on what? Available resources, and based on results. I call them the 3 R's. Is it a gap that will bring a high risk? Let's say, for instance, you don't even have an IPC program. So you know that one, because that's what every other thing is based on. So that's a high risk area. Just use that as an example. And then if the resources you require to address it are something that I can easily assess or something that will be difficult to assess, that's what you should address in developing your priority areas. And then, is it something that your results can be obtained easily? That means low-hanging fruits. Because when you have low-hanging fruits, when you have results that you can easily show, then it's easier for your facility management to believe in you and work with you on the journey. So always look for things that are low-hanging fruits. Always look for things that your resources are not things that will break the bank, and things that the risk is high, such that by the time you address it, it will improve your scoring or your rating when you now repeat the assessment. And then look at things in the beginning. Always go for things that you can achieve short-term versus long-term. When we're talking about sustainability, you can bring in more long-term programs. And we all know that, as I mentioned earlier, that when it comes to implementing or developing your plan, you have to bring in what? The multimodal strategies to ensure that your plan will what? Succeed. So this is a sample of what an action plan looks like. So based on the IP curve, on the first core component, which is IPC programs, we saw that there was a gap when it came to having an IPC team lead, IPC dedicated staff. So what's the required action? Develop a business case for IPC staff within the facility. Then who is the person that can address that? The CMD, the CMAC, or depending on what kind of facility, human resource department. Then what timeline is given? What's the budget or requirement? What is the financial implication? You can see that it's low because you can repurpose a staff from one area to that. So that's just how you develop an action plan. This is another sample action plan that looks at IPC guidelines. So at the end of step 3, which is developing your action plan, you should have your action plan developed and should have your prioritized areas. If, for instance, amongst your gaps, you needed an IPC program, you needed an incinerator for waste disposal, you know it's going to take you it might take you a longer time. So based on the 3 R's I put in earlier, which one do you need fewer resources? Which one are low-hanging fruits? Which one is higher risk? Just quietly go for a program and achieve your 3 R's, while you put the other one for a longer term project, where it will be easier for you to convince your management to invest that resource. Then what are the potential barriers and solutions? You review them and see how you can address them and ensure that they are addressed in your plan. And then the tools require and resources to support your implementation. If you remember, the build it stage in multimodal strategies addresses the availability of resources and tools you need. Then you need to do what? You should have met with facility leaders and stakeholders to discuss your action plan and ensure that this plan is part of the agenda of your IPC meetings at team and committee level, with action points, ensuring that everything is being implemented. Then you also determine when you conduct a repeat assessment to be sure that your action plan is working. That now brings us to step 4, where we are now evaluating the impact of our interventions from the action plan. So how do we evaluate impact? You need to track your progress. Remember, you have an action plan, and then you have your results from your IPCAF assessment in step 2, where you did your baseline assessment. So review the scores, review the action plan, ensure that your action plan is addressing the areas you picked for priority based on your IPCAF scores. Then you bring in all your relevant data and look at what worked and what didn't work. You now do what? Repeat your assessment using the same tool, which is the IPCAF. So what are the results telling you about what is working and what is not working? So when you repeat your assessment, just as you needed to be objective when you did your baseline, so also you need to be objective here as well to ensure that your action plan is working, your interventions are working, and that you have addressed the gap. Then you also need to discuss with your committee and make notes that will guide your discussions after the assessment with leadership and other stakeholders. Then prepare a presentation using the sample presentation slides in the module or in the manual, which you can get at the end of this presentation. So when you have done your repeat assessment, are your scores improved? The priority gaps that you had identified and put in your action plan for intervention, did they help to improve your scores at your repeat assessment? So at the end of step 4, which is your assessment, your repeating IPCAF, you should have completed your assessment. Then you have compared your results in the repeat with what you had in your baseline to see your progress, whether you improved, whether you remained stagnant, or whether you even depreciated. Then present these findings to leaders and other relevant stakeholders, those in the world, your link nurses, the facility management. Then based on your repeat assessment, you need to develop a new action plan, because definitely you might now discover that your former worst performing areas are now your best performing areas. So you now have new areas that are worst performing. So you now develop a priority area or identify a priority gap based on the 3 R's: the resources, the results, and then the risk. And then you agree, when are we going to conduct a repeat assessment to see whether our plan, which we are not going to develop at the end of step 4, is working. Then, of course, at the end of such activity, you need to have what? Apart from the immediate feedback you have given to stakeholders, you need to have a report, which you now give to senior management, to senior managers and leaders. Remember, taking pictures at your repeat assessment, as you did at baseline, is also an important priority. So from pictures, you can show where we were and where we are. Then the last step is what? Sustaining the program over the long term, which is one of the very, should I say, which is quite a very important part to address, because you need to ensure that the program is what? Sustained. So how do we sustain the program long term? You need to review and improve your program regularly. How? New actions. Can you bring up new projects? Remember, we said the core components address the basic minimum, so you can even go higher. Can you bring in new projects? Can you bring in campaigns that can help to institutionalize IPC? Can you bring in things that becomes a norm in your facility? Like I mentioned, awarding wards that are best performing. By the time you bring in competition, nobody wants his or her ward to be the lowest in performance. So there will now be healthy competitive spirit, and people want to ensure that whatever it is that the program that is being implemented, they are doing well and adhering. Then you build on communication channels. Because of your planning at your preparatory stage, you start communication with your facility leadership, your relevant stakeholders. Never allow your communication channels go to sleep. Sometimes at the end of the month or during festivities, the committee nothing stops you from wrapping a gift or parcel to facility leadership to say, thank you for being a good champion. Baraka de Salah, Happy Christmas, Happy Easter. It is part of the politics, ensuring that your channels remain open and you have good rapport. So don't kill your rapport that you have already established. It's a critical part for ensuring that your channels remain open, facilities business. Then you need to develop ongoing review and engagement cycle. That is one way that ensures that, like in that picture, where you move from picture A to picture B, to ensure that you do not go back to A, but rather improve. So for instance, let's talk about hand hygiene. Let's say you now have a hand hygiene program established. How do you ensure that the program doesn't go down the drain? You need ongoing review. Are the IEC materials tattered? Do they need to be replaced? So before they get absolutely tattered, there should be a program in place to ensure that you replace them. Are the consumables usually going out of stock after 1 year when people think that the program is going to sleep? So you need to ensure that a system in place that ensures that your consumables are still always available. That way you can ensure sustainability and continue to improve on the benefits of the program. Then you now utilize your action plan to guide you in developing a longer term program. Things that couldn't fit into your short-term plan because you needed short-term goals you could show your management cannot fit into your 5-year plan. Like we talked about the incinerator, this cannot fit into a 5-year plan to ensure that you are improving your IPC program. And then regular meetings with stakeholders. Then very importantly, you should have creative ways you can use to showcase your successes. Be able to tell your story. You should be able to have publications so that people that need to learn from your experience can find the available papers. And then very important, tell your stories at conferences. When your facility management is seeing you are doing well, they will be able to sponsor you to conferences to tell the story of the facility. And you can use the work you have done to apply for grants, which can also make your work easier. So at the end of step 5, where you're doing your sustainability, these are the things you should have in place. You should have an annual cycle when it is agreed now that you repeat your assessments. You should have your 5 plan ready. You should have secured commitment with facility leadership, and they're having good interaction with your champions. And as I said, paying them visits, sending them messages during relevant celebration days. And then you should have been able to start publicizing your successes so far. So in summary, I would like to say that the WHO core components for IPC is a leveler. It's something that can enable any facility anywhere in the world, whether low income or middle income, to level with high income countries. And then it simplifies, it structures, and ensures institutionalization of IPC in healthcare facilities. Then the multimodal strategy in IPC program implementation is a game changer when it comes to implementing IPC programs. It is what has helped to turn the dial. Then you need to build a team and be your greatest cheerleader, because sometimes you have to be able to self-motivate yourself to ensure that you can keep up the pace. So the WHO core components for IPC is what makes movement from A to B and remaining to B possible. So these are resources. I have links to these resources here, and I think I'll say thank you at this point. So if you have questions and comments, we can have them. I think. So thank you, Amaka. Over to you.
Thank you so much. Thank you so much, Dr. Joan. Such a very elaborate, section. Thank you so much for sharing from your wealth of experience. Let's appreciate, yes, you're already doing that. Please let's appreciate her using our best emoji. Thank you so much. We really, really appreciate. And I'm sure we have our thoughts put together questions, contributions, comments, and we'd love to have it. And I trust that Dr. John is still on the call to take those questions. But in the interim, we want to have, interestingly, we're having our spotlight section today. For a few sections back, we've not been able to do that, but we're having that today. So it's a beautiful thing. After looking at implementation of WHO core components, we're going to, look at and we're going to have this opportunity for someone to share experience on how they've been able to implement some of these things in their facilities. And joining us on that is Mrs. AB. She is the IPC focal person for her facility. She's a public health nurse and IPC focal person for Dead Koki Memorial Hospital, Bayelsa. And currently she's on the call. I'll be going ahead to share her slide. Mrs. AB, you're welcome. Thank you so much. I want to believe that we're going to learn a lot from what your facility has been able to implement so far. And you have the floor. Thank you. Let me project your slide now.
Thank you. Good afternoon, everyone. It's my pleasure to be joining us. Please, can you hear me?
Yes, we
Hello.
can. Just a little bit louder. Yes, we can.
Hello, we can hear you.
Good afternoon, everyone. My name is Nurse Evi. I'm from Bayelsa State. And like our moderator said, I am the focal person of my facility, which is the Tekopi Memorial Hospital here in Bayelsa State. And I have to be precise. And this afternoon, I want to say I'm honored and I wish to appreciate the previous speaker for breaking it down in a very easy manner. Thank you, Ma. I enjoyed that session. This afternoon, I'm going to be sharing my experience. Please, can you hear me?
Yes, we can.
My experience.
Go ahead.
I'm going to be sharing my experience based on how we manage to overcome some of the obstacles we encountered last year. So we'll just start by saying that Detekoki is a secondary healthcare facility here in the Lagos State capital. It is a general hospital, and we have a lot of traffic. We have our wards, we have a lot of things, but we have always had issues with waste disposal and management in the sense that it was done just like that, anyhow, initially. So I'm going to start with the introduction by saying that it has been a problem. And we all know that health care waste is a major contributor to environmental pollution. It is not well handled. It is hazardous to both patients, healthcare workers, and visitors because in the long run, everyone is affected. Next slide, please. Initially, we were having our waste after being collected, we're disposing it just in an open space, and it gave rise to a lot of issues with cats, rodents, and even illegal scavengers within the hospital environment. So we were able to sit down and talk. And after all the trainings we had, we sat down, the IPC team sat down with management to actually talk about it and look for ways to proper solutions. So we identified, as you can see from the slide, we identified uncooperative staff as one of our issues. We saw that the waste disposal bags were not readily available, and when they were available, they were not enough to serve everyone within the hospital. So people were improvising and dumping and using whatever they could actually use. They would have a dump site too that had a lot of problems, and everyone was actually concerned. Next slide, please. The next slide, this is how we were before the intervention. It was so bad that you could find up to 30 cats sometimes every year. They will mess it up. It was a terrible sight, and it was a heartbreaking situation for those of us in the IPC team. Before the IPC team and management sat down to brainstorm and look for solutions. So this is what we have before. Next slide, please. So we had a vision, and the vision was to change behavior. It was to change behavior, construct something that was cost effective, and to also monitor it in such a way that we could arrive at a solution whereby everybody will be involved. So this vision was communicated to management, and management saw it was an embarrassment to us. And behavior modification was supposed to come using multimodal strategies, the 5 steps of it: the planning, the policies, the building, the living, the checking, everything. And at the end of the day, we were hoping we have a culture of safe refuse disposal, which was what we were able to do. If we look at it carefully, we're able to achieve these things, but it took time because we're trying to look at where we're not getting it right in terms of behavior, where we're not getting it right in terms of supplies, and we're also looking at how we can improve what we had. Okay, we had a system, yes. We had our cleanup, our health attendants, but there was something missing, which was that sense of order and responsibility to own the fact that we were the ones generating the waste and nobody was coming to save us. Next slide, please. That was our vision. Now, this was the plan. The major goal was the construction of a storage site that was cost effective, using locally available and easily sourced materials to construct these things. So we were aiming for a rodent-free, cat-free, and scavenger inaccessible storage area that will be within the hospital, but it will be easy to access for staff that are disposing of things. It will be protected from rain. They will not have leakages and other things around it. Then it will always be accessible to professional waste handlers that will come at specified intervals to evacuate our waste. Then one other funny thing we observed was while planning, we wanted to make sure we're able to maintain it by cleaning and decontaminating from time to time. Next slide. This was the plan. Now, the intervention was easy. We started by having education and training of staff. When I mean staff, I mean health attendants and cleaning staff together. And it was in 2 phases. In the initial part of the training, we did an assessment of what they knew about disposal, that is the collection, the bagging, transportation of waste. And after we did that, we were able to assess what they knew and what they did not know. And given the fact that we have been trained, we were able to, communicate what was real, what was proper in waste disposal to them. So we had 2 sessions. The first session was a training proper, while the second session was a practical session. It was done on a day, and I can tell it was fun. It was fun because everybody came out, all the cleaners. We had one of our deputy directors, who is a member of the team. She came out with us, and it was a long day. We spent over 2 hours cleaning, bagging, arranging everywhere, washing all the bins. Everything was done. And there was joy because everybody came out that day with that determination, that motivation to make it better because everyone was tired. So I would say that in this intervention, the staff were actually motivated, not with money, but with a desire to improve what we had from that point A of doing it anyhow to point B, which was the point of doing it together in a healthy way that will protect visitors, patients, and staff from infections. Now, the team was part of this training. We had representative of management and other members of the team. And we also have interested members of staff, stakeholders that were very influential. And these people came together with the team to plan for that cleaning and bagging and utilization of the space. Next slide, please. Okay, now this picture is my favorite. We have a lot of videos and pictures, but this is my favorite. Now, if you look at this picture, you'll see my deputy director of services. She was sent by management to motivate, mobilize, and manage us that day. So everybody came in These pictures were taken after the construction. As you can see, it's a nice structure, but very valuable because we have to think of using the the net, barbed wires to keep out the rodents. I can tell you that after this structure was constructed, the cats were not happy with us. On a lighter note, the rodents were not happy with us because they would just come, move around, and there was no accessibility. As you can see, we kept a door. We have a door, and we're using a padlock to lock up after disposal. Next slide, please. Okay, so this was the storage area in use. This structure did not cost up to 200,000, and it was funded by management. They were benevolent enough, supportive enough. In fact, they were more excited than us to fund this project for us. Everybody came, and this was how we bagged it. As you can see, it's in use, and from that time last year till now, we've had one or two challenges. Next slide, please. I'll stop them in the subsequent minutes. Now, this is the conclusion of the whole matter. This storage area was actually accepted by everyone, from admin to clinical staff. Everybody was excited, everybody was happy. Now, it came to the issue of monitoring, and we found out that monitoring was the bedrock of the whole thing. We were grateful for the structure, we were grateful for the training, but monitoring was continuous around the clock because we had issues with adherence. Adherence was a problem. Why? Because we have some people that will just go and fling it around, so we have to go back again and start cleaning like that. Then we also have people that will go, they will not bag it properly, they will not tie the bags properly, and somehow it spills out again, and we'll go around again, we'll motivate ourselves. Volunteers came out. I'll go around, I had to go around with my team, and I have health attendants and cleaners and volunteers. When they mess it up, we'll tidy up again. We'll now place adverts like monitors, reminders on all platforms across the hospitals, from administration to nursing platforms to theater. We'll go physically and we'll communicate our desire for a better storage area. And eventually, people began to buy into the idea. And I can tell you that from that period last year, middle of last year, when it was constructed, till now, it is better. Yesterday, I went there. This morning, I went there to check again. I can't show you pictures, but I can tell you that everybody is behaving properly. So everybody is motivated. When they go in, they are not repulsed by the smell. They are not repulsed by the sight of it. Everybody is comfortable. Now, evacuation. We decided with management that evacuation of waste will take place on alternate days so that it will not be overfilled and it will not smell. And that has been maintained. So I can tell you can actually walk in there comfortably and do what you want to do. Now, in terms of monitoring, audit, and evaluation, I believe that we'll still improve because there's always an opportunity to improve with what you're doing. When the previous speaker said, evaluation and maintaining that tempo is important, I agree with that because accountability is everybody's business, and everyone here in my facility is everyone's accountability partner. If just someone not doing the right thing, you walk up to the person and politely say, please tie your bag properly. Please transport, please double bag, do it well. And so far, so good. Everybody is everybody's accountability partner. We are hoping that we'll maintain this tempo. And I wish to say that everybody is now aware in this facility that waste management is a shared responsibility. And when I say shared responsibility, whether you're a doctor, generating waste, you're a nurse, you're a pharmacist, you're a lab scientist, waste management is everybody's business. And because of the fact that these trainings were done, education and training, everyone knows that IPC is here to stay. We just hope that with the commitment of management this year, 2026, we'll be able to achieve a lot more in terms of IPC and the core components of IPC. Thank you very much for having me here.
Well, thank you so much, Mrs. Sebi. Very interesting. Thank you so much. Let's appreciate her. Thank you for sharing. Beautiful to see what's going on in your facility. Good, beautiful to see some of the things that you are able to do there. And interesting to see that everybody is being held accountable, a collaborative effort of everyone to achieve what you aim to achieve. And then also recognizing the rooms for improvement. That's a great one. So let's appreciate that. Thank you so much. Thank you, Mrs. AB. And to every one of us, we can see from these experiences and her facilities that she has shared with us that this WHO component that we're talking about is not just theoretical. They are practical, they are evidence-based pillars designed to, strengthen IPC at both national and facility levels. We're speaking to structure, leadership, training, surveillance, monitoring, workload, and infrastructure, and that is a beautiful thing for us to see this afternoon. So thank you so much, Ma. And now we're opening up to questions, contributions, comments. Is there something you want us to, you want to share with us? Do you have questions for the speakers? Dr. Joan is here. I can see a hand up already. That's good. Interesting to see that we're able to make this session interactive. So Dr. Peter, go ahead. You have the floor.
Good afternoon, all.
Good
Please
afternoon.
confirm. Oh, thank you so very much. Thank you so very much. This is a wonderful topic and well presented by the two that I listened to. My concern actually will be directed to Dr. Joan HMB. I would just want to create a scenario for her to help me out. There are challenges of implementing these IPC programs in correctional facilities. One, I mean, maybe like prisons within Nigeria. So it becomes a bit difficult because those environments are well-established environment for infectious diseases transmission, of which is well-established globally, even worse within our own environment. And because of there are lack of so many resources within this environment, how can one actually establish this multimodal strategy? So what advice will she have in such an environment in order to improve despite this lack? So I just want her to just give me like a heads on so that one could also use that as an opportunity to develop, because there's nothing happening. From what she's saying, most of the environment has no of these IPC programs on ground. Thank you, and over.
Thank you. Dr. Joan, so he's asking, using the scenario of the correctional facility, what they can do. Dr. Joan, please go ahead.
Thank you, Dr. Peter Mede. That's a very interesting question. I would like to ask, are you a first person or you work in a correctional facility?
Yes, I do. Yes, ma'am.
Okay. And in fact, when I heard your question, I felt guilty because for some reason, we always talk about facilities. We tend to forget about such areas. And just as I mentioned, they're a thriving ground for transmission of infectious diseases. But the same way you go about setting up a program in a facility is the same way you go about setting up a program in a correctional facility. Just as I mentioned, when it comes to your first stage, which is what? Preparing for action. So now, I assume from what you said that programs do not even exist there. But I'm sure you should have something like a healthcare facility within, or people who are ill are always taken out of the facility.
There are healthcare facility within.
Okay, so that's a good place to start. Why? Because from your facility, you can now take your changes into where healthcare workers are. Sorry, I say healthcare workers, where inmates or those that are being corrected, where they are kept. If a good place to start for you now will be, you don't even have a program existing. So you now need to, as I said, look for how you can form a team of people that have like interests and like passions. Then are you equipped, as in, do you have the requisite skills? If you do not, Ethic is a platform you can reach out to. We can get a facility of people that can mentor you to ensure that you get the appropriate training. Then, as a correctional facility, if you are a uniform personnel, you can start with small gains to develop a position, as I said, position paper, to be able to present your management the reasons why you need to have established at the facility an IPC program. Then, for the fact that it's a correctional facility, is an area where you can have, should I say, philanthropists that will be interested in investing. So if you conduct a baseline, if you look at the resources available, what do you have in your program? Do you have nothing at all? Do you have at least human resource that are willing to work with you to enable you to develop a team? That aside, who are the important people you need to talk to? The stakeholders. You can even have stakeholders among the prisoners. I know Nigeria is one place where you can have very, very senior people who are incarcerated in a particular correctional facility. They can even be part of your stakeholders because they will have access to people that have resources and funds. So that's your planning stage. So you've talked to your stakeholders, you've developed a team that can drive this vision. And then your position paper, your position paper, you do not have a program existing at all. Meanwhile, your facility is one that is a thriving ground for transmission of healthcare-associated infections and even infections within where the inmates are being kept. Then you now bring out your tool. You do your baseline assessment using the IPCAF. So you now know how well or what you score on the various score components. So you now look at your scoring. Okay, as I talked about the 3 R's, your results, your resources, and your high risk. So your high risk, which are the area, your worst performing areas, that is very grave risk, that by the time you talk about it, either on social media or if you approach somebody that can be a philanthropist, the person will be, or your management, the person will quickly want to address it. Then, what are the resources you require? What are the resources you have available that can address amongst your gaps, that can help you determine which one you can start with first? And then what will enable you to achieve quick results? What is your low-hanging fruit? So weighing your risk, available resources, and your results, you can determine which priority areas you start with. So by the time you start with a priority area and have some gains, you can use that to help to further bring in your management on your vision, which is to ensure that your incarceration unit or whatever it is, correctional facility, even though people are being held there and are considered inmates are supposed to be under correction, they are living a good quality of life and that they are being kept safe. If you look at correctional facilities abroad, some people won't want to go to prison so they can have good quality of life because you receive good square meals, your environment is clean, and in some cases, they are even protected from people you want to avoid in the outside environment. So for when you have people with you, you need to ensure that they are kept safe because they are still human beings. We talk about human rights, patient rights, they are still human beings. So the fact that it's a correctional facility does not mean that the place should be allowed to run down. And because it's a correctional facility, I can tell you, we can get people that be interested in supporting you if you can show the little that you have done. Then having done that, your baseline assessment, you now develop a plan. Okay, how can I move from where I am now, point A to point B, with the priority gaps that I have identified? I remember you're always carrying along your stakeholders. Usually when you start, remember in my conclusion slide, I did mention that you have to be your best cheerleader. If you wait for people, will always want to tell you, this thing no go work, or anyhow, you no go work. But as long as you can keep yourself motivated and cheer yourself on, when you now start getting successes, all those that are singing to you that will not work, they will come and want to become part of your team. So do not let naysayers talk you down, especially because of the environment you find yourself. So you now see what, with your plan you have now drawn, based on what priority gap you want to address as regards the various 8 core components. You now put your plan in place and then monitor it using the multimodal strategies, because that's what you used to implement, and then determine when you now do a follow-up assessment. Okay, was I able to change the narrative from what it was at baseline to what it is at step 4 when you're repeating your assessment? So what was my win-win? Then this is where you blow your trumpet. You celebrate your wins. This will bring you more management support, will bring philanthropists to support you, and will bring the naysayers on board your ship. And then you repeat, it's your step 5. What plans do I have to ensure that I can stay where I am? That's your picture B, your new achievements, and not go back to what it was before. That is institutionalizing your program, which is something that you repeat again and again. Because each time you repeat your assessment, you discover that your worst performing areas would have improved. So you now have a new worst performing area and areas of higher risk. But the area you are is an area of interest where you can get people that will be willing to support you, as long as you can show this is what the situation is, this is what I'm able to do, and this is what I can do if I get further support, and this is what can go wrong if I do not get the needed support. Do you understand me? Or
Very
did you
well.
understand? So we can continue this conversation after this meeting, because actually we hardly think of correctional facilities, to be frank. So I'm even glad that you voiced this out.
We are always abandoning the programs now.
No, that's right. That's why I said I felt a bit of guilt.
Yes,
But
ma'am.
thank God you have raised this. So it's something that we will explore going forward.
Thank you. Thank you so very much. I appreciate it.
So maybe you will send your contacts to the program manager so we can continue this conversation. So I think there's some
Okay.
other Amaka, you can see who is who.
Yes,
So
yes, I
okay.
can. Noted. His name is noted. All
The
right.
Thank you.
other people have their hands up.
Yes, we
Can I just chip in? This is very, very interesting. And we cannot finish this discussion on this program. I'm so glad that you came up, Dr. Peter. But I would like to know, do you have a clinic within the correctional center, or do you take the inmates out? Because we need to know exactly what you're talking about, so that we give some other people to ask their own questions. We can't finish
Yes,
this
I will
discussion
do.
there. Do you have a
Okay.
clinic? Pardon?
Yes, we have a referral clinic in 6 centers. That other places are just like a health post that we do. It's only cases
And
that
where are
are
you
not.
located?
Me personally, I'm at the facilities in Bauchi State, man. We have a hospital within.
Which state? Which state?
Bauchi.
Bauchi State, man.
Okay, we will talk. Let's take the other questions, because this discussion will go on. We can have a WhatsApp discussion later, because I think we need more details. Thank you. Over and out.
Okay.
All right,
Over to
ma'am.
you, Amaka.
All right, thank you, Ma. Okay, so thank you so much for the contributions, everyone. Okay, so quickly, I'll take the first hand that was up. Patrick, Dr. Patrick, please go ahead. You have the floor now.
Hello.
Okay, we can hear you, sir.
Okay. Yeah. Okay. Good afternoon, colleagues. Dr. Ejembe, I really appreciate the efforts at institutionalizing control. It's very critical that at the primary healthcare systems level, we've had certain improvements, especially in the area of political will, but we're hoping that the federal government, through the National Health Sector Reinvestment Initiative, would strengthen readiness by ensuring that the revitalization has a WASH component that is a critical part of whatever infrastructure that the federal government wants to put at the primary healthcare level. Because in Kogi State, His Excellency the Governor Ododo Usman Ahmed, he has put in value. Close to 198 facilities have been revitalized. So the uptake of services has improved. But the idea about readiness is that there's a gap because readiness, when you're classifying readiness, you identify wash alongside with commodities, cold chain. There are causal linkages that lead to failure or even dropout rates from lack of proper infection and prevention control. So we're hoping that the federal government can improve the institutionalization at the primary healthcare level. I want to appreciate your presentation so far, especially in the area of describing, providing opportunity for a theory of change. So it's important that the primary healthcare tool be built in to your framework, your objectives, so that you can expand the scope of infection and prevention control and help the federal government to come out with policies that can embed this infection and prevention control in a way that at the facility level, it will be appreciated much more than it is now. Thank you so much.
All right, thank you so much for that contributions and also the comment about improvements at your facility. Because we do not have so much time, I'll quickly give Dr. Abiodun the opportunity to. Dr. Abiodun, you have the floor for your contribution or comments.
Is that the
Good
Dr. Abiodun
afternoon.
and you?
Yes, Dr. Abiodun, please go ahead.
Yes, good afternoon, everyone.
afternoon.
And thank you so much, Dr. John, for such a wonderful presentation. I don't think we can talk about this topic too much because it's the foundation of everything you want to do regarding IPC. If you get it right at setting up the program, then whatever program you want to focus on, you're going to achieve it. So regarding the question posed by the correctional officer, regarding IPC in congregational settings, I think is quite germane, and my comments have been addressed in some way because I wanted to tell him that mentorship, because he's quite new to it, he will benefit a lot from mentorship. Someone that, or rather an organization that they can reach out to that will help them set this program up in this setting, because it's quite new. We're usually in facilities, but in his own setting, he will need, more assistance than what you can discuss at this forum. And I'm glad that Dr. Joan and Dr. Abimbola has already offered to offer him, this help he requires. You can also reach out to your state IPC focal person. I believe that is something that they will want to assist with. Thank you very much.
All right, thank you so much. And very importantly, like you said, he needs to reach out to the state IPC focal person. That's for Bauchi. I was just trying to remember his name. And then I have a question quickly for the second speaker, Mrs. Sebi. I wanted to know, please, Ma, are you still on the call? I wanted to ask, Mrs. Sebi, are you on the call? I'm not sure. Please confirm that you can hear me. Are you on the call? Okay, maybe she's wanted to check since she's no longer on the call. But I had wanted to know if her facility had if they had functional color-coded waste bins in place, and I'll find out how much compliance, if they have proper segregation and how it's being monitored. But since she's not she's no longer on the call, I don't know if there are more questions, contributions,
Amaka,
comments. Ma.
I think since you have her contact, you can send her a private message.
Okay, Ma.
If she's not on the call, it will be the network.
Okay.
Then I wanted to mention to the last one speaker that you are talking about government, the PAC. Is the NCDC that is handling infection control at the national level, is to get NCDC, and I believe they have zonal offices and state offices to work with the MPACDA, because that would make it more sustainable. But if you just say federal government, we need to be more specific. And then we are there to help wherever we can. Thank you. Over and out.
All right, thank you. Dr. Patrick, hope you noted what she said.
Yes,
Okay.
In
I
addition,
did.
in addition to that, sorry, in addition to that, if you remember, the core components addresses both tertiary, secondary, and primary level. And each state has a facility IPC focal person. I think it's a lady for Kogi. I can't remember her name now. So this is a forum where we can all work together to ensure that everybody is carried along. Just as I said, this is supposed to be a leveler to ensure that whichever level, wherever you access care, as a patient, as a healthcare worker, you are protected, you are kept safe. So thank God we have an existing structure now. So it's not so difficult as it was previously to ensure that what is required is put in place. Thank you, and over. But we can also continue this discussion after this current meeting.
All right, thank you so much, Dr. Joan. Dr. Isa, your hand is up. Is it the one, like, do you have something more to say?
I've lowered it. Thank you.
Okay, all right, that's great. Okay, so thank you. Any more questions, contributions, comments? I wanted to say that we had shared a link previously to everyone's email. We wanted to know what areas that we want us to focus on during our subsequent IPC trainings on this eco platform. And we will still appreciate the feedback. The responses have been quite low. And so I'm going to reshare that link again in the chat. Please take out your time to give us your feedback. We want to know which topics, which areas would you want us to focus on. The year, it's a new year. This is our first section in the year. So we have about 10 more sections to go for the year. And it will be very interesting for us to find out which areas that you want us to focus. So the link is in the chat. Please use that link to give us feedback, comments, contributions. We have open-ended questions where you could, let us know, give us your feedback. So I've shared it and I look forward to getting your responses so that you could help us with our planning. Thank you so much. And then I would like to introduce Dr. Joan, your hand is up. Please go ahead.
Okay, I saw somebody asking from Liberia asking about the conference.
Yes.
That's what I was trying to draw your attention to.
Okay. Thank you so much for noting that. I can even see that we have people who are joining from,
From Cameroon.
Cameroon. Yes, I saw that. And
I saw somebody from Cameroon.
Yes, I wanted to acknowledge.
So maybe you should share, if you can share that link, or we can send it to them, but you can share it now. But remember, people still have to give feedback for this session, this beautiful session by Dr. Ejendi, Joan, and our other sister. We need to have your feedback.
Okay.
So please, can you share that as well?
Okay.
Okay, there's one question here I think we need to address.
All right.
As a healthcare worker, who do I complain to outside my institution if I do not get the safe environment needed? Stella, please, can we discuss this? First of all, management does not like to be reported. Remember, I talked about negative occurrences sometimes being the opportunity you have to ensure that IPC implementation can be kicked off. So what we call occurrences. So if there's a negative occurrence, use that. I don't know if your facility has an IPC focal or you're the only person there. I don't know what kind of facility you are working at. If there's an IPC focal person, or there's a team, or there's a committee, and you're part of them, or you're just somewhere in the facility who is concerned. I remember I said that people who have interests are very important human resource that you should use. So it's not about reporting per se. Use whatever the negative occurrence is as an opportunity to ensure that implementation, which is, if it's not properly done, can be kicked off and can be improved. I hope I have addressed your comment, but you can always speak to us so that we can help guide you on how best to address what the particular scenario is, in case you do not want to unmute and speak yourself. You can reach out. Amaka, that's somebody
No,
else's.
I'm unmuted.
Okay, yeah, we can
I'm
hear
actually
you.
unmuted. Yes.
Okay,
Thank
fine.
you so much for this wonderful presentation. I work in an institution, government institution, one of the military hospitals, Air Force Hospital precisely. And the way military do their things. It
Yeah.
doesn't matter if you are a civilian, you are higher up, as long as you are not in uniform. There are some things they will tell you, this is the head of this is like the hygiene in my place. There was a day I walked into the hospital and I saw splashes of blood in the consulting room, and somebody said it has been mopped that morning. You sometimes, so I don't really, when you complain, they will come and do it. There will be no hygiene.
I think your network. Stella, we can barely hear you now. I think it's your network.
Well,
Alternative.
Amaka, I think you have just note her name.
Okay.
You contact her, we will send an email to her or a text or WhatsApp message, and then we can pick it from there.
All right.
Dr. Joanne Ejembi, I'm sure we have somebody in the Air Force that we can link her up with. So in a tactful way, she can handle this program so that she doesn't go headlong complaining. Otherwise, they will just block her out.
No, I'm here, ma. This is Dr. Gordia.
Dr. Gordia.
Good. So I'm glad that you are listening, but we will link her up with you.
Yeah,
So
I
that
think
we find
she just
a
have to
tactful way, of
Mm.
resolving this, because she shouldn't just go and be showing off that she just listened to one program. We'll just shut her up.
Yeah, I think it's opportunity. I know Coach Stella. She will just reach out to me, and
Okay.
just Amaka, tell her to reach
So
out to
Amaka,
me.
you link them up,
And,
please.
Okay.
She'll
Thank you.
be able to be guided through.
Thank you
No
very
problem
much.
about that.
Okay. Thank you, Dr. Godian. Thank you. Okay, so I'll quickly, introduce our flyer. I've projected it and drums rolling. Interesting to say that we have our conference coming up, our National Conference on Infection Control, and the theme is Infection Prevention and Control as a Pillar of National Health Security. This is our save the date flyer. It's the conference will be coming up 19th to 21st of August 2026 in Abuja. So please mark your calendar, and plan towards it. It's really going to be an interesting time to come together as IPC professionals, policymakers, IPC enthusiasts. So looking forward to seeing everyone. And secondly, our call for abstract flyer is also out, has all the details. I also want to project that, but we're sharing it on various platforms, and I want to believe that some of us have seen it. Somebody was asking, I think it's David, that he's joining from Liberia and he would love to attend. It's a beautiful thing to hear because the conference is opened up to everyone, IPC professionals from not just Nigeria. We're looking forward to receiving people from different parts of the world yet. And so you're welcome. And the registration will be opening up soon, 5th of March. You'll get more information about that, about registration details, how you can register, secure your dates, accommodation, and all of that. So all those information will be coming up soon. But if you need further information, do reach out to us via email, ncnigeria@gmail.com. And also we have the phone numbers. The flyer is up. You can see it on the screen. So more questions, then reach out to us and then we'll give, share more questions. But subsequently, we'll continue to give out more information about the conference coming up in August 2026, and plans are in earnest. And we look forward to having you there, looking forward to seeing everyone in Abuja. So thank you so much. This session was recorded. We're going to be sharing with everyone. Please don't forget to use the feedback form. Let's hear from you. How do you want us to plan these sections differently? What are the topics that you look forward to seeing, areas that you want us to focus on? And remember that our sections is every last Thursday of the month, and I look forward to seeing you again next Thursday. That's the last Thursday in March. So thank you for everyone that has joined. Thank you to our amiable Dr. Johan. Dr. Johan, thank you because I want to say thank you especially because you're always available to support, to be able to help in the planning, and also contribute your experience and your knowledge, insights on IPC with us every time, and we really appreciate that. Thank you to Mrs. AB. It was a great one seeing some of the things that you're able to say. I want to say well done to you, ma, because sometimes it's one thing to conceive an idea, what you want to implement, and it's another thing to, take it through. And seeing that success story, I want to say well done to you. Thank you to everyone who has attended today, the early participants, those who joined, everyone who stayed to the call. I know that our time is exhausted, but really appreciate you for being able to join. Dr. Johan, you have something to say? All right, go ahead, ma.
He's saying you should share link.
Ma?
We share link. Look at the chats.
Okay, my screen. Let me look at it. Okay. All right. Okay, attendant, the link. Okay. Someone saying network is bad. Okay, Stella. Okay, ma, when you left, we said that we're going to link you up with Dr. Godian. So I'm going to, share your email. You can drop your email address or your number. And then, okay, I should reshare the link. All right, let me do that. Let me,
Okay, solution for Stella.
ma?
But the other thing is the person who complained about the military setting.
Yes, and she's back on the call. So
I
I'm
know that there's an MOU with NCDC and the Department of Defense. I don't know whether her facility, and she's beyond that DOD now. Is it? There's an MOU with NCDC and Department of Defense.
okay.
So
Yes, but in a situation where they are not compliant, that's what I'm talking about. When they don't do what they are supposed to do.
that's why I told you the two things. One is it's an avenue for you to.
Yes.
And secondly, you might.
I agree with you. I think I will implement those because
So it's not about who to. You look at it as an opportunity for improvement. Then I know that there's an understanding between Department of Defense and the Nigerian Center for Disease, the IPC program, that Nigerian Center for Disease Control, which is the national IPC program. So that's where that's another piece can get guidance. Dr. Godian, I know because you see if he's a first person, or he works, so he can also give you some guidance on what to do as well.
Okay, I want to believe that that is noted.
I understand. I just think that an external, maybe any external force just came, not like accusatory, just to make sure everything, it keeps them on their feet once in a while, because with this Lassa outbreak and seeing rats and everything these days is really scary. But once in a while they still need to be put on their feet. No problem.
Who
I
is the
understand.
facility? Who is the IPC focal person for your facility?
You don't even know, because every time it's only the cleaners and the cleaners are not really staff. I think they are contract staff. When you say who is in charge, who do
Sorry,
I?
Stella, which facility are you now?
063.
I didn't even know that you are
Stella.
here.
Yeah, Stella, which facility are you now, please?
063. Even though today, actually, because we had today I actually complained to the commander because we have a new commander now. I complained to him.
Who is your commander now? Who is the commander now?
He just came. I just met him twice now.
Okay.
One
What happened that
doctor
we
just
can talk
Who
off
say that to
camera
call
after
Amanda's
I
name?
think you should
Oh, God.
continue this
you
discussion privately,
yes, you have my number,
because this
Stella,
is
so that we talk.
an
All
open
right.
space, please.
Good.
no
So
problem.
please, you can
Yes,
call me
sir.
later so that we discuss. You can chat me up. You know my
Measurable.
contact.
Since you know her,
Yeah.
you can call her after the meeting.
Okay. Thank you.
All right. Thank you, Uba.
So at this moment, we draw the curtains. Thank you to everyone. Your comments, contributions, and questions. Everything was really appreciated. So at this point, good evening, everyone, or good afternoon, and I look forward to having you again next section. Bye.